Welcome back to Mice TV, live from the CAKE and PIE Expo in Da Nang, Vietnam. This is our second broadcast for the second day of the show, and we had quite a first day and night. How are you doing today, Matt?
Well, I'm feeling a little bit rough, but at least it was for a good cause. A lot of people showed up to support Orbis in their cause to end preventable blindness around the world.
And of course, he's talking about the fundraising party we had last night on the rooftop. We do have a highlight reel of that we'll get to later. But first, what do we have coming up today?
Well, our first live segment is an interview with Dr. Sheetal Brar, which is, we're going to have this hot topic of femto laser versus phaco and cataract surgery, so can't wait for that one.
And for the retina surgeons out there, Dr. Diva Kamp-Meester will be on a PIE Talks with Media Mice CEO Matt Yum. They'll be discussing eye care for diabetic patients, which we know with rising diabetes rates is quite a big topic right now, and it's important.
Absolutely. Yeah, and later I'm going to be interviewing Dr. Isha about Botox and filler in ophthalmology, which is a really, really interesting topic that not many people know a lot about.
I certainly didn't know that you could use Botox in ophthalmology.
Yeah, it's really, really interesting.
Okay. All right, we also have Dr. Kaur and Thacker on. They'll be talking about glaucoma and how there's more to managing glaucoma than just topical drops. There's different things that we can do to, manage to help improve outcomes.
Yeah.
So we're really looking forward to that talk as well.
Absolutely.
Yeah.
Yeah, so there's so much more coming up today. What do you, I think we got a highlight reel coming up.
Yeah, we actually have a highlight reel we're about to play from yesterday. So let's roll that clip and see what we missed.
Yeah, let's check it out.
Day.
Years ago, we began a journey at Media Mice to communicate about eye care in a fresh and innovative way globally. We saw innovations in medical devices and therapeutics all around us in eye care. What we didn't see was innovation in communication. We believe eye care is a fascinating subject matter to discuss. That's why you are all here. This means ultimately, because of our unique flavor at the CAKE and PIE Expo 2.0, doctors and most importantly patients win. Thank you and enjoy the expo.
So according to WCO's stage of optometry training,
half of my career at least, there was a lot of tension between the two professions, but I think
cycle in a dead pattern, even over the fovea region, and there was a resolution of the fluid, but not much improvement in vision as well.
Welcome back, and what a day one it was. You know, one of the really interesting things about that video were the shots of the exhibition hall. Brooke and I had to film a couple of segments for booth walkthroughs, and we had to wait and wait and wait. I mean, it was packed down there.
It was, and you know, I love when I see that at these different scientific conferences.
Absolutely.
It's, you know, the industry partners are big supporters that allow us to even put on these events. So when everyone goes down and really learns more about all the innovations and products that they've brought to the table, yeah, it's always really, really nice to see that.
Yeah, I had a lot of fun going to and learning about the products. Dr. Shri, for example, explained a lot about the Pentacam that I didn't know, and I know that you had fun at the CooperVision booth.
Yeah, we actually have some videos from those booth tours coming up a bit later, and I even got a trial pair of lenses to wear, so we'll be talking about that a bit more too. Okay. Next up, we've got probably the most exciting highlight reel. We've got the Orbis fundraising party. If you weren't there last night, you might have missed out on something, but we've got a few secrets to show you. All right, stay tuned. Let's watch.
We had a cool day today, and I think we're going to have a cool night now.
Orbit is committed to continuing joining you in the long journey ahead. With the slogan, changing the world we'll see.
And actually, I don't think it matters how much it is. I think anything that you can give will be appreciated. So, you know, thanks to Media Mice, thanks to Orbis.
I couldn't help but see that you were lovely as can be.
CAKE and PIE Expo 2.0. CAKE and PIE Expo, come on, you know you want it.
Wow, so that was a really, really fun party last night. As you can see, we had live music, we had dancing, and the CEO of Media Mice?
Oof.
What happened there?
Well, I'm not quite sure. All I know is that our next guest, Dr. Brar, found herself in front of Matt Young, CEO, and the poolside. I could watch that over and over again. What about you, Brooke?
We have watched that over and over again.
Yeah, and speaking of Brooke, man, you had some dance moves out there.
I have talents that nobody knows, apparently. Discovering new ones every day.
Absolutely, and it was, you know, I'm feeling a little bit rough this morning, but it was all for a great cause, so that makes me feel slightly better.
Yeah, and you know, I want to thank CooperVision and All Eyes. You know, they sponsored the event at the 4 Point Sheraton. We were up on the rooftop partying for a good cause, which was Orbis. Orbis was there as well, and all the proceeds last night went directly to supporting their mission of preventing avoidable blindness.
Great, so.
Next up, we have Dr. Shatil Brar. We'll be right back.
So I know. Yeah, for sure. Nice to meet you. Please send me an email with all the information and we'll make it happen. Okay, cheers. Thank you.
Welcome back to Mice TV, live in studio in Da Nang. We are here with Brooke and Dr. Sheetal Brar, who is a cataract and refractive surgeon from Nethradama Super Specialty Eye Hospital in Bangalore, India. Good morning, Dr. Brar. Welcome to the show.
Good morning.
So one question, you were out there late with the crew last night. How do you feel this morning?
By the way, was that me?
It was you, yeah, and I think you were involved in...
You sure there's no doppelganger of mine going around in this meeting?
Oh no, I don't know.
I'm a serious ophthalmologist, an academician.
Yeah.
I don't push people in pool.
No, totally not. So did the other Dr. Brar have a good time last night?
You can ask her.
Yeah. So, you are a cataract and refractive surgeon, is that right? And we're going to be talking about phaco versus femto today.
Yep.
So, tell me a little bit about that topic. What are the pros and cons? What do you use in your clinic?
So, I come from Nethradama Eye Hospital, Bangalore, India, and ours is a high-volume cataract and refractive surgery center. We offer both phaco as well as femto to our patients. And I would say in terms of the ratio, the percentage, when we started femto technology, we got the femto technology in our institute in 2014. Our femto numbers were actually probably just like 10% of the total cataract surgeries. But now, over the past few years, it's almost 40 to 45%. So you can see every year there's a steady growth in the number of femto procedures that we are doing, and that's probably because of our patients asking for more and more premium lenses, the toric lenses and the multifocal lenses, which we all know, do better when there's a well-centered and a regular capsulotomy, which certainly is only possible with femto always, and not with phaco always.
Great.
Yeah, that's very interesting. That's actually what I was going to touch on, what you would attribute that increase to. And it does make sense, there's so much talk about, toric IOLs and all the more premium IOLs. Great.
Yeah, so what would you see as some of the major pros and cons of femto and phaco?
Yeah, so I think I'll just discuss the pros and cons of femto technology, because if I discuss the
we'll be here all
we can
go forever.
The entire
yeah,
10 minutes of the interview will be consumed. All right, so femto, of course, there are lots of advantages. I personally I love to do femto procedures. That's because the most important advantage that this technology has to offer is customization. So you can customize the capsulotomy, whatever size you want, you can program it wherever you want. You want it to be centered on the pupil, on the limbus, on the capsular bag. Sometimes you have subluxated cataracts, so you want a decentered capsulotomy, so that's only possible with the femto. And also nowadays the newer platforms, they are coming up with the customization of the fragmentation based on the nuclear density.
Right.
So they grade the nucleus density, and accordingly they plan the chops. So it's not surgeons basically headache to kind of plan 4 chops or 6 chops or 8 chops. So the laser does by itself, and also the AIs, the arcuate incisions. They're such a big advantage. I have a talk today. I'll be talking.
I think we're going to get into that a little bit later.
Yeah,
well, I was just going back to the femto laser, and you talked about the chopper. So does that, if you have this femto laser, do you need less tools or devices? Can you do the chopping with the laser, or do you still need the chopper to get through those denser cataracts?
I think up to grade 2 to 3 nuclear sclerosis cataracts, it does very well. You really do not need an additional instrument. Of course, you need a chopper to gently separate it though, but in very soft grade cataracts you can actually use an OVD cannula and separate it just with the OVD. So we have described this technique and we have also published it. It's called the visco chop.
Okay.
Wow, nice.
That's interesting.
Yeah, I have a paper on it.
And
that's for this very soft cataracts. You really do not need a second instrument. But definitely grade 4 and grade 5 cataracts, those very hard brown blackish cataracts where the posterior plate is really thick
Right.
Sometimes the laser does not penetrate that deep, so you do need instruments and additional manipulation.
Okay, very good.
Let's shift gears a little bit here, because I think this is a topic that a lot of cataract and refractive surgeons are curious about. Let's talk about people with astigmatism preoperatively.
Yeah.
So what kind of options do you have for pre-op, people with pre-op astigmatism?
Yeah, so as we all know that preoperative astigmatism of 1 diopter and more is so common. Almost 47% patients come with astigmatism, and this is so important to correct, especially if the patient is going for premium IOL again. You cannot leave the patient with residual astigmatism of anything more than 0.4 diopter, because they're going to have a bad quality of vision. So there are different options that you can choose from. The easiest is to actually just place the incision on the steep axis, but sometimes it can be a bit challenging, especially if the axis or the meridian of the cylinder is an oblique one, and you have to make an incision from the temporonasal side. It's a little challenging. And then you also have the option of opposite clear corneal incisions. And of course, time-tested technology of LRIs, the manual LRIs, they are very much in place and still widely practiced. Yeah.
So I guess the other option is going to be toric IOLs. So
definitely.
So how do you choose between each?
Yeah, I think the most important factor that you have to consider is the amount or the degree of the preoperative astigmatism. So our LRIs or the femtoarcuate incisions, they work well up to 1.5 to a max of 2 diopters of astigmatism.
The lower
astigmatism, yeah. But anything more than 1.5 or 2, I think definitely we should go for torics, because they offer a stable and much more predictable results.
Right.
Yeah, great. So let's zoom out again. So we've talked about, femto laser for astigmatism and things like that. What do you think is the future for both phaco and femto? I mean, do you see one becoming much more common in use, or do you think there's room in the market or in the treatment space for both?
I think for now, both technologies are very much in, and depending upon the surgeons' expertise and availability of resources, they with both the femto as well as phaco are being practiced. But I think I just saw the results of a recent survey, and it showed that there has been a steady growth in the number of femto procedures by 1.6% every year.
Wow.
So what I can see is that over a few more years, maybe a decade or so, probably the femto procedures are going to be more in numbers, and they're going to probably take over phaco. But phaco is always the gold standard. It will always stay.
I hear a lot of chatter about the cost of femto, and I mean,
yeah, definitely. I think that's the main limitation of the technology.
Yeah. Now, I mean, you do most of your work in India, which is revolutionizing, low-cost medical devices and things like that. Is there something on the horizon in India, maybe for lower-cost femto machines, to make this more accessible, or what do you think about that? What do you know?
I really don't think so. Any femto laser machine is, cost-effective compared to others. But the high-end machines actually can do a lot. The machine that we are using is the Lensar, and it also offers us marks for toric placement, so like IOLs. So
you don't have to do manual marking.
No. We don't have to do any manual marking. No ink required. No markerless system required. So that's one big advantage.
Often these femto lasers come with more than just the laser.
Yes.
Yeah, they come with a suite of maybe software and other tools that can really,
Yeah, so thanks for coming on the show. Is there anything else you'd like to add today?
I think just one message to the young generation, the young phaco surgeons: do not ignore astigmatism. It's so important to treat astigmatism, and even if it's because cataract surgery is not just cataract surgery now, it's cataract refractive surgery. Patients want uncorrected 20/20 vision. So whatever works in your hands, the best, maybe manual LRIs, or if you have access to femto or whatever. Just do not ignore this. Try to correct it so that you can have happy patients and better patient satisfaction.
Great. Well, thanks again for coming on. Brooke, what do we have next?
Well,
thank you so much, guys, for
Yeah,
the opportunity.
Yeah, let's thank Dr. Sheetal Brar for coming on again and talking about this important topic. Next up, for the retina side of things, we have Dr. Divakant Misra. He'll be providing a diabetic eye care guide for patients. Let's watch the video.
Hey Divakant, welcome to Mice TV. Thanks for joining us.
Thank you so much, Matt, and so happy and excited to be here.
Well, you know, Divakant, I've just read an article featuring you in the Times of India. Congratulations.
Thank you so much.
So according to that article, 74 million people have diabetes, I saw, and 39 million people live with undiagnosed diabetes. This is, of course, all in India. You know, this accounts for about 8% of the Indian population. It's always been reported in literature that diabetes is an epidemic in India. In your clinical practice, what percentage of your patients are diabetics, would you say?
I would like to say that it's a global epidemic as of now. If you look at the data by the International Diabetic Federation, there were 460 million diabetics in 2019, which is supposed and expected to rise up to 700 million by 2045. Unfortunately, India is the diabetic capital. On a busy day, almost maybe up to 30 to 40% of my patients are diabetics.
Is that because of the dietary issue, essentially? I mean, every time I come to India, I'm always eating gulab jamun, for example, but is there this Indian fascination with sweets, or what is really the cause?
We are genetically predisposed to diabetes. So we have a strong genetic predisposition to that. The high insulin resistance that is seen in Indian, there's a lot of central obesity, visceral fat, and all of these things lead to insulin resistance and higher incidence of diabetes. And in various studies, we have also seen that the physical activity is, especially in the urban Indians, is supposed to be low. With the dietary modifications, the Western diet coming into the Indian diets, so it's all high calorie, high fat, high sugar. So all of these things lead to diabetes.
Well, can you elaborate on what are some of the most common conditions that diabetic patients coming to your clinic suffer from in terms of the eye?
Diabetes affects multiple organs in the body, most of the parts of the eye. Top three things, that is cataracts, affect the retina and lead to diabetic retinopathy, and it can also lead to a form of glaucoma that we call as the neovascular glaucoma.
How can diabetic retinopathy, as you mentioned, be caught early in these patients?
We have to have that understanding that the effect of diabetes on the eye can be devastating. People can go blind so easily if the disease goes unchecked. Once you know that you have diabetes, you have to get your eyes screened on a regular basis. If a type 1 diabetic patient is there, he should get eyes checked within the first 5 years of being diagnosed, and a type 2 should get it done as soon as possible. And if you're found not to have diabetic retinopathy, then you need to do it on an annual basis at least. And if you are a diabetic, then it has to be, of course, more frequently depending on the condition of the eye. There are various tools that we have that affect us, that aid us in screening and diagnosing these diseases. One is the clinical examination through 90 diopter lenses, where on a slit lamp, we can clinically diagnose the patient. And there are certain instruments, certain machines that help us. We can document the photograph of the retina. Now, artificial intelligence is coming in a big way in diagnosing through these photographs and scans. And without even a trained physician or a trained doctor, the AI will in the future help us to diagnose through simple scans. Another is the OCT scan, optical coherence tomography, where we can look at early edema that can be caused due to diabetes. Then angiography can be done, OCT angiography can be done. All these things help in catching the disease early.
Well, you've talked about prevention, but when it comes to diabetic retinopathy treatment and management, what are the modern possibilities?
So prevention is the number one thing, as we have discussed in the previous question. But when you have that disease and you have the various symptoms and signs of that disease, then we have a lot of options on the table. Number one, of course, is a good glycemic control. If we spot some early changes of diabetes, then we have to ensure that a good glycemic control has to be there. Not just glycemic control, there are various other factors that need to be controlled, like the hemoglobin of the patient, the blood pressure of the patient, the lipid profile, the kidney profile, vitamin D, and the overall health of the patient has to be monitored and controlled well. So that will prevent the disease from progressing, and that will also, at times, it helps us in reversing the process of diabetic retinopathy. But once the disease starts and we have to give some treatment, there are largely three types of treatment that we have. The anti-VEGF injections or steroid injections. Whenever we see a lot of neovascularization or a lot of edema, then we need to inject the patient with these drugs. Then the number two thing that we have are the lasers. Now the role of lasers is diminishing over the period, but it definitely has role in proliferative form of the disease, where we can further prevent the proliferation of diabetic retinopathy, and at times we do it to reduce the edema in the eye as well. Number three is the surgery. Now when we see that there is a lot of traction on the retina, or we have proliferative kind of a disease with vitreous hemorrhage, tractional retinal detachment, then we definitely need to go in for surgery. So vitrectomy surgery coupled with injections, ILM peeling, at times we have to inject oil or gas to settle the retina. These are the options that we have to treat the disease.
Well, I understand that the diabetes rate in India is still lower than in some countries. Like, for example, in the US, it's 11.3% compared to that 8% in India. But of course, India's got this massive 1.4 billion population. So, the pressure from this huge number of diabetic patients that can develop eye conditions could certainly burden the whole eye care system. How are eye doctors working together to address this issue?
The number one thing that we focus on, as we discussed earlier, is the awareness and screening. So in my center also, and the previous places where I've worked, and all of our colleagues are some or the other way involved in screening these patients. So we hold what we call as diabetic screening camps on a very regular basis. At least once in a month I do it in my center, and similarly all of my colleagues, and usually these are free of cost. What we are trying, a lot of the technologies have come in where we don't need to dilate the eyes to examine them, right? So that is a big hindrance when we see a lot of working professionals. They don't want to get dilated and get their eyes checked, because for the next 3, 4 or 5 hours probably you'll have blurry visions. So the newer technologies that we have, they can diagnose the disease without even proper dilation of the eyes. So that is helping us a lot.
I know the Young Ophthalmologist Society of India, or YOSI, is a very dynamic group. And of course, you're the secretary at the moment. How is that society addressing this problem in India?
Just one quick update. So recently we had elections, and now I'm the vice president of the society.
Congratulations.
Yes, this has been for us an important issue. Our parent body, the All India Ophthalmic Society, had in the last few years before the COVID, they had organized and had given funds for diabetic screening camps. So that is something that we are also working on. A lot of young practitioners, people who are new into practice, may not have funds to organize these camps or take the burden of that in the early phase. So we are trying to help them out in terms of technical guidance, and hopefully with some funds as well in the future.
It certainly all comes down to education. So how can doctors raise awareness for the population about having a regular eye checkup if you have diabetes?
So I think number one thing would be platforms like Mice TV here, which will definitely help in getting the word out. You can get on a YouTube channel, get on your Twitter, Facebook. There are a lot of people who are connected, our closed ones, our friends of friends, right? So we need to have this message about at least the important diseases like diabetes, retinopathy of prematurity, diseases that can be prevented from progressing by intervention, by some other modifiable risk factors. So the message should be out, and we all should utilize the power of social media, take help from people like you to get the message into the society about these diseases.
It strikes me that, over the time that I've been covering Indian ophthalmology, the country was certainly working to eradicate the cataract backlog. But you being part of this young society, in India, it makes me wonder whether the future is, not only cataract, but these retinal diseases. Is this sort of the new frontier of the so-called disease backlog?
So cataract used to be and probably is still the #1 cause of diabetes, apart from things like refractive error and others. We have done great work in terms of cataracts. The focus is slowly shifting onto other things like glaucoma and retinal diseases. And amongst the retinal diseases, two things that are very important, as I mentioned, one is diabetic retinopathy and the other is retinopathy of prematurity. So awareness is slowly increasing about these diseases. A lot of government initiatives are coming. Another thing is that the number of retinal experts is going up. A lot of people are getting trained, and now people are taking responsibility and creating awareness, putting pressure on the government. So a lot of work has been happening, and hopefully within the couple of years we'll have some great projects and great screening projects for this disease.
Well, Divakant, thanks for joining hands with us here at the launch of MICE TV, raising awareness not only in India but around the world about important eye conditions. You've been a great guest. Thanks for joining us here.
Thank you so much, Matt. And as we said, that the awareness is very important, and I'm sure that this new Media MICE TV will help us in doing that. And look forward to further collaborations on a greater scale.
And we're back, MICE TV, coming to you live from the CAKE and PIE Expo in Da Nang, Vietnam. Now, a big part of any conference is the exhibition hall. So we made sure to take some time yesterday to take a walk through our exhibition hall here at the Expo. And first up, we have 2 interviews with some of our biggest supporters. We've got Oculus coming up to you, followed by Cooper Vision. Let's watch.
Hi, I'm Matt, host of MICE TV, and I'm here with Shri from Oculus. How are you today, Shri?
I'm doing good.
Now, Oculus is one of the oldest eye care brands in the world. I think over 125 years of history.
Last year we completed 125 years.
So what are you showing us here today? Let's start with this.
We have the Smart Field, which is a visual field device. This is basically a device which does not require a dark room. Unlike a normal visual field, it just takes less than a minute to do the screening, and we recommend this to be used in all cataract preoperative screening so that the patients are aware of if there are any visual field defects in that. We also have a new state-of-the-art device called Myopia Master. So what it does is, it's along with autorefractive keratometer, optical biometer, we are partnered with BHPI to give you a new progression growth chart, which indicates and tells you the progression of myopia much before it's seen in other devices.
Great. So you mentioned screening. What other parts of a myopia treatment program does the Myopia Master serve?
So here we have the optical biometer, and we also have the autorefractive keratometer. So one device can do both the things and also the graph. So one is basically a patient education tool as well, because as you know, the kids don't decide for themselves. It is the parents that decide. So you need to have them educated as where the myopia is heading to.
Great, yeah. What about doctors? Is there, how long is it going to take me to learn how to integrate this Myopia Master into my clinic?
For hardware point of view, it just takes less than a minute to take the screening and then the interpretation, because you need to have a questionnaire with the parent and the kid. Great. So that's about 1 or 2 minutes. So in 2-3 minutes, you're done with the patient to get all the reports generated. And that even the follow-up is needed, right? Because you're talking about progression. So this will help you monitor the progression once they come time and again.
Great. Let's take a look at the Pentacam here. This is one that I'm personally excited for.
We have, the Pentacam. Fortunately, this year we are celebrating 20 years of Pentacam once it's first started in 2002.
I think one of the things that is a hot topic in ophthalmology right now are IOLs.
Yes.
And premium IOLs. As we get into this next generation technology, we need higher levels of sophistication for things like biometrics.
Yes.
How is Pentacam meeting that need?
We have already done our studies scientifically and compared it with the gold standard IOL Master 500 and 700 by leading doctors, and it's already been published. So we are also, working in getting the space where we are being termed as the gold standard for cataract as well. So we already have more than 500 leading intraocular lenses database inside the device for the next generation as well.
Well, Shri, thank you so much for joining us on your booth tour.
Thank you, and wishing you good luck for the show as well.
Thanks. It was really great to see the devices, and I'll see you around the show.
Hi, welcome to the CAKE and PIE Expo. I'm here at the exhibition hall, and right over here we've got the CooperVision booth. I'm here with Hamish, and he's about to tell us about some of the products they brought to the show today. Welcome, Hamish.
Thanks, Brooke.
Yes.
Well, we're from CooperVision. We distribute contact lenses throughout Asia Pacific, including Vietnam. But specifically, we're here this weekend to talk about myopia management.
Right.
And myopia management in children.
Okay, that's interesting. So I understand that you brought a couple products to show us today, and I know the first one is right here. These are the MiSight? MiSight one-day disposable contact lenses. And what is unique about this product?
This weekend, we're actually talking to ophthalmologists and optometrists about whether or not MiSight is something they would incorporate into their practice for myopia management for kids.
Right.
But this is a soft one-day contact lens that a child can use. We usually start them around the age of 8. But they can use them up to whenever their eyes stop growing at 15 to 20 years of age.
So contact lenses for children.
Correct.
Okay, so let's talk, how user-friendly are these? I can't imagine it must be difficult for children, or you've thought about this?
Absolutely. Actually, I think that's a bit of a myth that contact lenses aren't good for kids.
Right, okay.
A lot of our evidence shows that kids actually adapt really quickly. They develop good habits, and they're actually better at using contact lenses than most adults.
Okay.
So it's quite a low risk in terms of kids using contact lenses.
And let's talk about the importance of using these contact lenses to stop the progression of myopia.
Right.
Why is this important?
Yeah, absolutely. Great question. So myopia in its early stages is something very, very common across Asia. We see rates up to approaching 90% in some countries.
Right.
And most parents see that as an inconvenience where you can wear spectacles and just correct the vision. What they don't see, though, is that the damage that it causes to the back of the eye. And in adult life, there's a lot of visual impairments that can happen as a result. So if we slow down myopia and make it less when they're kids, the chance of them having an issue when they're adults is much less.
And that's exactly what we want.
Exactly.
Well, before we sign off, I know that you have one more product you'd like to talk about, and that's an orthokeratology lens. What is this lens?
So orthokeratology is slightly different to the MiSight one-day product, which is you throw away every day.
Right, okay.
The orthokeratology product, and we have two. We have the IC product and the Paragon CRT. They are a reusable lens that you would sleep in overnight.
Okay, an overnight lens.
An overnight lens.
Right, okay.
And it actually reshapes the front of the cornea. So it has the same effect of kind of correcting vision. So when you wake up, you take out the lenses, you can see perfectly.
I'm sitting here with Casey from CooperVision, and we're going to talk about the innovative lens design behind CooperVision's contact lenses. Welcome, Casey. Thanks for being here.
Hi, Brooke. Very happy to be here. It's amazing. So MiSight One Day is a daily disposable soft contact lens designed specifically for children starting from 8 years old. And it features a unique optical design, which we call the active control technology. In the center, there is a correction zone for the vision, and surrounding it, there's a treatment zone to induce defocus to slow down the progression of myopia.
Wow, so this contact lens, it not only allows them to see in their daily activities, but it also stops their myopia from progressing. Now, where are these contact lenses available in Asia Pacific? Where can doctors get these lenses?
Yeah, so in Asia Pacific, we have it in a lot of countries. It is approved in China, Taiwan, South Korea, Singapore, Malaysia, Hong Kong, Australia and New Zealand. It's waiting for approval in Vietnam. I'm hoping that we would be able to bring it in as soon as possible.
Well, thank you so much, Casey. And that's us from CooperVision reporting live at the CAKE and PIE Expo. All right, and I understand that you have another product here today, the Paragon CRT, and these are an orthokeratology lens, is that correct?
Exactly. So very similar to my side one day. These have zones as well. The black part that you see over here is when the kids wear the contact lenses at night, it's going to flatten their cornea, and in the morning, it's going to correct the vision. And over here on the green side, it's going to steepen the cornea and induce that defocus that we want to have to slow down the myopia progression.
Well, thanks to Dr. Devakant Misra and Matt Young for that informative talk and look into diabetic eye disease. Stay tuned to MICE TV for more Pie Talks coming up today. But first is something you definitely don't want to miss. It's the CooperVision and Oculus Corporate Symposium. CooperVision for their innovative contact lens design, and we know Oculus for their devices like the Myopia Master and Pentacam. So Matt, I'm wondering, how much do you know about axial length and its role in myopia progression?
A little bit, but I'd like to know a lot more.
Well, good for you. We've got two leading myopia experts, Dr. Lilian Fu and Dr. Hui Tran. He'll be here at the CAKE and PIE Expo 2.0 to share their best practices during this symposium called Axial Length and Myopia Management, getting to the root of the problem. So remember, 11:30 today, and you can submit any questions you'd like during the symposium. We'll be right back.
So I know. Yeah, for sure. Nice to meet you. Please send me an email with all the information and we'll make it happen. Okay, cheers. Thank you.
Welcome back to MICE TV, live from the CAKE and PIE Expo 2.0 in Da Nang, Vietnam. And thanks, Brooke. Don't think we can all wait for that symposium, excuse me. In the meantime, though, we have a special treat, a CAKE talk on Botox and fillers in ophthalmology. I'd like to welcome Dr. Isha to the show. Welcome to the show, Dr. Isha.
Thank you, Matt. It's been an honor to be here.
No, thank you. So how are you doing?
I'm doing great. I'm doing great. It's like my second time to Vietnam and first time to Da Nang.
First time to Da Nang.
Yes, and it was amazing. The Orbis party last night, we had a lot of fun and it was amazing.
Yeah.
Very nice.
So what are some things you've been doing in Vietnam since you arrived?
So Matt, he recommended me this spa, herbal spa, and me and my colleagues went for that. And it was amazing. They use like herbal balm and some hot stones, and it released all the toxins after that long flight.
Oh,
and
yeah. How long was your flight?
It was actually just a 4-hour flight, but I had a 7 hours delay. So
okay, that's a long day.
Waiting at the airport and sleepless nights,
Yeah, you needed the massage.
So I was not focused on the food, but the massage.
Great. So let's get into our topic today. Now, I was looking at your LinkedIn profile, and you wear a lot of hats. You have a lot of specialties. Why don't you tell us about all the things that you do?
Well, so I am basically an ophthalmologist, but I practice as an advanced cataract surgeon, an oculoplastic surgeon, and a facial and ocular cosmetic surgeon. So what I basically do is I do all kinds of cataracts, simple, complex, complicated, and referral of cataracts. I do oculoplastics. In oculoplastics, we do mainly like lid, lacrimal, and orbit. So in lid, we do like different kind of cases like ptosis, entropion, ectropion, reconstruction, trauma, and everything, tumor removal and then reconstruction. In lacrimal, we mainly have like, you know, duct blockage and at which level, and then we decide the management. And in orbit, we have like different kind of tumors, trauma reconstruction, and these are the things I basically do in oculoplastics. Well, in cosmetic, the things are advancing, you know. So as an ophthalmic surgeon, we have limited scope, but things are increasing, like, you know, blepharoplasties, eye lifts, kind of mid-face lift, and we do like non-surgical treatments like Botox and fillers and different kind of lasers. So these are what, you know, the patients want these days. If you're a plastic surgeon, they don't only come to you for surgery, but also for the non-surgical treatment. So, you know, it has got a very wide scope of services these days,
Medical school must have been quite busy for you with all those specialties.
Yeah, medical school was super busy, and following that, the super specialties were even busier.
Yeah, so let's talk a little bit about those subspecialties. Oculoplasty. I mean, what made you decide to take this up?
Well, as a confused resident, like every resident is confused, So after I finished my residency, 3 years in India, I was very confused, like, you know, should I take up refractive surgery? Should I take up cornea? Like, you know, what should I do? And then I was like, I started doing cataracts, and slowly I shifted to complex cataracts after residency, and I had a fellowship. And then I was like, let me get into, you know, oculoplastics, because I slowly started doing these surgeries on my own. And then I was like, I kind of like this branch. And then I got into the fellowship program. I was at UCLA for 3 months, and I got into UCLA, and after that I did another fellowship in, you know, in our country. And now I have a training lined up at SNEC. Like,
oh, great.
Yeah, at Singapore.
When are you going there?
I'm going there in October.
Oh, okay.
So yeah, it's a short one, just for 20 days. But I think these are important to keep brushing up your skills, right?
Right.
Like,
continuing your education and your practice, and definitely it never ends, really.
It never ends, and it's fun that way,
So let's talk about Botox. Now, this is botulinum toxin, excuse me, and I think most of our audience is going to be familiar with that through the anti-aging, anti-wrinkle. So, you know, why do you use this? What is the mechanism of action of this bacteria in ophthalmology?
So what happens is botulinum toxin, what we already know, it's produced by a bacteria called Clostridium, right? And what happens is in our body, like it, you know, it has got a neuromuscular junction where acetylcholine is released, and then the muscle contracts, like any muscle, be it facial muscle, be it the muscle of the hands. So what botulinum toxin does is when we inject botulinum toxin, it gets into the neuromuscular junction and it prevents the release of acetylcholine. So when it prevents the release of acetylcholine, it, you know, the receptors are empty. There is no acetylcholine binding to the receptor, and hence the muscle don't contract. So now take it on the wrinkles. When your muscles are not contracting, the wrinkles are not happening.
So what kind of conditions are you using this for? Kind of treatments?
The Botox?
Yeah, Botox.
Yeah. So Botox, we use it mainly for functional and cosmetic purposes. For functional, you use it for blepharospasm, hemifacial spasm, migraine. You know, these are the things you use in functional condition. In cosmetic condition, there are like various conditions. So first you have to see if the wrinkles are static or dynamic. If the wrinkles are static, that means even while you're not talking, when you're in the rested state, you have got wrinkles. So Botox can do nothing much in that state. What it can only do is in the dynamic state, like when we are talking and the wrinkles are appearing, right?
So if you lift your forehead.
Exactly, yes.
And then they come. You can tell I haven't had Botox because there are lines when I raise my eyebrows.
Exactly,
my eyebrows still move.
Yeah. So yeah, we do it for the frontalis, which is the forehead Botox, the crow's feet, which is the orbicularis, under eye, then nose, the lips for smoker's line, and these are the various places where we use Botox very commonly.
Yeah, now quick question. As Brooke and I were preparing for this segment, I mean, she mentioned she hasn't had Botox. I mean, you're injecting a poison into you. Does that, I mean, like, how do patients feel about that? Do you have people that just say, ooh, I don't want that, or is there a lot of resistance?
No, I think people are very well read these days, you know. So how the Botox is processed and produced, it is very regulated. Yeah. So that way our patients are safe. In fact, all the medicines that are being produced and marketed are safe because everything is derived from something or the other. Like not all the medicines have a natural derivative. So everything is processed and regulated very well. So I think it's pretty safe. Yeah.
Let's change over to fillers, because that's the other half of our talk today. So fillers are things, more anti-aging stuff, volumizing things like lips, cheeks, in cosmetic surgeries. What kind of ophthalmic or clinical uses do we have for some of these fillers?
For fillers, we mainly in ophthalmology, the most commonly done indication is under eye filler, which is for tear trough deformity. So tear trough, it can be of various kinds, but mainly it's for hollowness. You see these under eye hollowness the patients have, and also sometimes the patients come with initial stage of eye bags. So eye bags, the big ones, you know, the huge ones people have, that cannot be cured by fillers. That will need a lower bleph. So the initial stage of the eye bags we can camouflage with fillers. So patients can be satisfied for a year or two, but ultimately the patient will need a surgery.
Yeah, so another thing that it is really interesting.
Stuff that you don't really even think about, because we don't touch on this quite as often, so it's so great to have you on the show and your specialty.
Now, I do have another question. When I was researching this, there's so many different things that you can, so many different types of fillers, so many materials.
Of course.
What do you have a recommendation for all those who are thinking about incorporating this, or what's the best?
So I'll tell you something about fillers. Fillers have got different derivatives, like all medicines have derivatives. So we basically classified into 4 categories, which is heterogeneous, allogenous, auto, and synthetic. So in hetero, we have another 3 categories, you know. So one is from bovine collagen. So which most of the bigger companies like Galderma, Restylane, all of these companies, they are using those materials, right? Another is from human collagen. So human collagen is kind of safer, but we also have a better material these days, which is the hyaluronic acid. So the hyaluronic acid, it is a heterogeneous material, but much safer for all kinds of its indication, right? Another one we have is allogenous, which is, like I said, it's from human collagen. Another is autogenous. So what we do these days, we are using a lot of nano fat graft. What is it? It is from the fat of the person itself. That is a complex surgery, but safer. Safer because it's its own material. It's it gives a very rejuvenated appearance because it's their own stuff, and you can even you can get a good quantity. And the others are synthetic fillers, which we don't generally use, like silicone and
really
stuff.
it's just so interesting. I mean, most people think, oh, cosmetic surgery, but you're really just doing good for people who need it, and to feel better about themselves, and for a clinical standpoint, I think that's really cool.
For sure.
So is there anything else you'd like to add or say to our viewers out there?
Any doubts you have before starting Botox and fillers, just ping me. I'll be available to answer all your questions over email, over WhatsApp, I don't know, and I'll be happy to help anyone whoever wants to get into this subspecialty. And
great. Wow, that was, I mean, this was definitely one of the segments I was looking forward to most. That was really interesting, Brooke, wouldn't you say?
It definitely was. You actually might have convinced me. I didn't know you could get Botox underneath the eyes.
Yes, we can.
So thank you so much for coming on the show, Dr. Isha.
Thank you so much.
Thank
It's
you so
been a
much.
pleasure. Thank you so much.
Yes.
Up next, I had a chance to sit down with Dr. Peter Downs of MarketScope for a video entitled 10 Infographics That Will Change the Way You See the Ophthalmic World. Stay tuned and enjoy. Hey everybody, welcome to Mice TV. We are here with Peter Downs, who is a writer and analyst at MarketScope, and he's going to be talking about 10 infographics that change the way you see the ophthalmic world. How's it going, Peter?
Fine, how are you?
Pretty good. So why don't you tell us a little bit about what you do at MarketScope?
MarketScope is market research firm specifically focused on ophthalmology. We report on news in ophthalmology, and we have annual market forecasts for different segments of ophthalmology around the world.
So it sounds like you've got a lot of good stuff for us here today with these charts. So let's get started with the first one.
So this first slide is on, as the title says, cataract surgeries in India and China. I just find it interesting. Two countries, both developing economies and roughly the same size population, and they have very different levels of cataract surgery. The gap has been closing slowly, but there's a big change in both countries, but more so in India with COVID-19.
I have these World Bank statistics here that says China has about 20 million more people, so roughly the same. But China's GDP per capita is that nominal GDP per capita is actually 2.5 times higher than India. So what do you think might explain that discrepancy?
Two countries have had very different approaches to cataract surgery. China emphasized economic development first, and cataract surgery was mainly developed kind of a market-based surgery. So people could afford it, then they were able to get it. India took a very different approach, a very strong charitable sector in India, and they concentrated on developing very cheap intraocular lenses and other supplies using cataract surgery. Nearly 6 million, probably 90% of the cataract surgeries in India are either free or subsidized. Estimated manufacturers' revenues, looking from left to right, China's at the top in revenue, while having much fewer IOLs installed than India. India, on the lower right-hand corner there, is the clear leader in the number of IOLs, but they're very cheap IOLs. So the large proportion of people getting IOLs in India are still getting the hard lenses that are maybe $2 or $3 or each, compared to $100 or $150 for a flexible.
Other countries you mentioned maybe like between the 150 and 200 range in terms of how much each IOL costs. Why are manufacturing revenues in India so low? I mean, they aren't just low, they're incredibly low.
Yeah, so India has a number of India-based companies making very cheap IOL. Aravind is a well-known nonprofit hospital system in India. They have a manufacturing arm to make their own IOLs. They export to other parts of Asia, Africa, and Latin America, but even when they export, the price is a few times the price that they charge in India. And I find this interesting, just to look at kind of the top cornea problems in the outside of the most highly developed markets. They really vary by region. You know, Africa, you have trachoma is a much bigger problem than in any other region.
That big bar for trachoma really, really pops out at me. I know that organizations like Helen Keller International have been doing a lot of work getting that number down. Mali, for example. And countries like the Gambia have recently actually eradicated this disease. Do you think that trachoma in Africa is trending in the right direction?
Trachoma is very much a disease that is linked to the level of economic development. So as you get clean water supplies, you reduce the level of trachoma. I was really astounded at how low the level of cornea transplants Asia, Africa, Latin America is compared to the need. So Japan is a very developed country, and they have the highest level of cornea transplants per need. Even that is at 3.6%. Latin America generally is kind of a medium level of development. China, as you know, is probably pretty much on par with Latin America in terms of economic development, but the level of cornea transplants is much, much lower, as it is across India, Southeast Asia, and Africa. Comparing China, Southeast Asia, and India, I think there's a lot more cultural resistance to giving up corneas to be used in other people. Culturally, there's a lot more kind of cultural sharing back and forth between Latin America and the U.S. for more of some of the cultural attitudes and willingness to let the cornea be taken from relatives after they die. What really struck me, and the reason I made this slide, was just how far above the rest of the world that we're looking at China is.
Why do you think China seems to have such a maybe proclivity, you could say, for refractive procedures relative to their population?
So there is a huge middle class in China that is able to afford refractive surgery. The other contrast there, I think, is Japan. It's almost the leftmost there. You know, Japan has a case where you had leading surgeons 10, 15 years ago, very publicly spoke out against refractive surgery and said it was not a good idea. And that has really hindered adoption of refractive surgery in Japan. There are a lot of occupations where you're not allowed to wear glasses in China. There are a lot of, there's the army, other public security occupations. Yeah, so this is about the share of laser procedures in all refractive procedures. There at Japan at the bottom, Africa does not have that huge market, but laser surgery is a lot easier to do than incisional surgery where you're maybe putting a piggyback lens into the eye. This is looking at the proportion of the population that is receiving medicine. And we're talking about Western style medicines, chemical medicines. That's important, particularly in China and India, a little less so, where there's a long history of what's now called traditional medicine. In China, there are a lot of traditional medicines people might start taking when they first become aware they have glaucoma. And it's only after the disease progresses more that they move on to a Western style chemical medicine.
We have Latin America again with these impressive results.
Latin America, most of Latin America has been at kind of a medium level of economic development for a century. And so they've had a long time of manufacturing. They have a lot of well-established pharmaceutical companies. Most of the glaucoma medications sold in Latin America are generics. So they've made copies of expensive medicines developed elsewhere. I have grouped procedures here into three types, kind of the newer class of procedures, the microstents and canaloplasties. SLT, filtration surgeries, are the traditional glaucoma surgeries, the trabeculectomies and the tube shunts.
Lots of people are talking now, I know in our magazines we are as well, about things like MIGS. I mean, this looks like the future, but we can see from the chart that adoption is still pretty low.
The number one barrier is cost. I'll take India as an example. Prior to this interview, a week or so ago, I talked to a doctor in India who had performed some MIGS with the eye stent. Cost there was the equivalent of $1,500 US. They can do a trabeculectomy for about $20. We're looking at disease population and treated population. China, way to the left in terms of the size of the disease population, which is not surprising given how big the country is. Japan, way to the right, which in this division of regions is the smallest. So that makes sense as well.
Yeah, these proportions are pretty low across the board. I mean, even Japan is around a 10-to-1 untreated to treated ratio. Why do you think so many patients in these regions are going untreated?
So much of retina disease does not really have an effective treatment yet. The disease populations in this chart includes, for example, people with dry AMD or more advanced form geographic atrophy. There's no approved treatment anywhere in the world except Europe recently for those diseases. Southeast Asia and China, treatments are covered by insurance up to a certain limit. In China, it's been 4 injections and then that's it. It's not covered anymore. But these are endemic diseases. They last forever, so they need treatment forever. It's not a one-time thing. Great. Now this is retina surgery. Vitrectomy is needed. How much bigger market China is than everyone else?
We've been kind of like ignoring a little bit Southeast Asia and Africa. What do you think some of the reasons behind this are? I mean, the obvious one being just a lower level of socioeconomic development and things like that. But like, let's hone in on some real obstacles that aren't, that general in nature.
Retina surgery is a very highly specialized surgery. Very specialized equipment, not just in terms of vitrectomy machines, which is the basis of, but the hand pieces and other tools used in the surgery itself. They're expensive. So the level of training for retina surgery, it's a much more difficult operation than cataract surgery is.
Peter, thank you so much for coming on. We really appreciate all those insights. Very, very valuable. And yeah.
And it's my pleasure.
Welcome back to Mice TV, and thank you to Mr. Peter Downs for that really amazing conversation. Up next, we've got some more booth walkthroughs. Brooke had the chance to walk through the Seed booth. They are a Japanese premium contact lens maker. And I got a chance to chat with the guys from Aurolab who displayed a very, very wide range of extremely interesting products. Let's check it out.
Hi, I'm come over here at the Seed booth at the CAKE and PIE Expo, and we've got some innovative contact lens designs to show you. Tell me about Seed. What does the company do? What are you doing here?
Yeah, hello, my name is Takuya Yanagibori. I'm a General Director of Seed Contact Lens Vietnam. We are a contact lens company, and actually our headquarters located in Japan.
This is an orthokeratology lens, meaning it's worn overnight and actually helps control the progression of myopia. Tell me a little bit more about your orthokeratology lens.
Yeah. This, our orthokeratology lens's name is Blesso Collect.
Okay.
This is very unique material. I show you because orthokeratology lenses usually are made by hard, right?
Right.
But this lens is very
oh wow, it's very
flexible. Yeah.
Okay. That's
so,
very interesting.
which means the wearing is very comfortable, right? During the street,
yeah. If you're wearing them overnight, you want to be comfortable while you're sleeping.
Yeah.
And we've got one more product that we want to talk about. Now, I've heard of multifocal contact lenses. I actually did not know that there was extended depth of focus contact lenses using intraocular lens technology. So here they have the One Day Pure EDOF. Let's talk about this product.
This design usually use IOL lens.
Right.
Yeah, but we use this lens for contact lenses. Yeah, for the presbyopia.
Okay.
Yeah, but now many Japanese doctors, they think about we can use these lenses for myopia control as well.
Okay, great.
Yeah.
So this also has a myopia control element as well.
Yeah.
Oh, great. Okay, I didn't realize that. So what kind of patients, extended depth of focus, presbyopic patients. So these are going to be for patients that are probably maybe over 40, are starting to lose their near vision a little bit. So these contact lenses will give you ranges of vision from near to far while controlling your myopia progression.
Hey, it's Matt from Mice TV. We are live at CAKE and PIE Expo 2.0, and we are just outside the exhibition hall here. We actually had to wait. It was so crowded before. So we've got so many good exhibitors from industry. Let's go check it out. So I think we're going to go over to the Aurolab booth first, see what they have to offer.
Aurolab is a part of Aravind Eye Care System, which is Aravind Eye Care Hospital. It's a world-renowned institution in the world.
Let's talk about your IOLs. What are the advantages that those hydrophobic IOLs have over other IOLs?
Aurolab, we started with the PMMA lens, which is a hard lenses, and after that hydrophilic lenses. Now in hydrophobic, we have all ranges. Maybe you can look at that here. For the monofocal lenses and multifocal lenses, toric IOLs, clear IOL.
Wow, it seems like you have a lot of offerings. Now let's move on to this nice piece of machinery here.
This is our Aurolab slit lamp, which is one of the important diagnostic equipment. And now we can look at that. We can use this 3-step slit lamp with our applanation tonometer also, so we can measure the IOP. And apart from that, you can connect with our splitter slit lamp camera. So you can, whenever you do the diagnosis, you can see the pictures here. And then if you want to do the analysis, then you can save the picture and then you can include all the patient information. After 6 months also, if the patient's coming for the follow-up, then you can do the analysis.
Now, we have a lot of little things here. Take us through what you've got.
These are the very important product like a glaucoma shunt. In the worldwide, the bare-welt glaucoma shunt was there. It is completely, we got the pattern and then the same 99% equal to that. This is a non-valved glaucoma shunt, right? In the worldwide, the glaucoma shunts were available valve and non-valve. This is the yellow IOL. That is yellow hydrophobic and negative aspheric preloaded hydrophobic IOLs.
Thank you so much for joining us today.
Thank you very much. Thank you so much.
And if you're here at the CAKE and PIE Expo, come on down to the Aurolab booth to learn more.
And we're back. As a reminder, if you're here in Da Nang, Vietnam, attending our expo, make sure you check out the exhibition hall. You can see booths from CooperVision, Seed, Aurolab, and more. Well, that's a wrap for our first hour of broadcast today from Mice TV at the CAKE and PIE Expo 2.0, but we've got more to come later this afternoon. From 2:30 to 3:30 Vietnam time, tune back in as we interview Dr. Dottie Fidel and Dr. Thakor and Kaur as they talk about glaucoma management. We've got all that and so much more. We'll see you later.